Hi, good evening, everyone. Welcome to the ACP Problem Solving in Oncology webinar series. My name is Dr. Hamzeh Kayhanian. I'm a member of the ACP Trainees Committee and an SPR in Medical Oncology at the Royal Marsden in London, and I will be chairing this evening's session. This evening's webinar will provide you with an overview of colorectal cancer management, both in the early and advanced disease settings. The educational content of this evening's meeting are entirely non-promotional, but we're proud to have the webinar series sponsored by Eisai and Roche, world leaders in oncology pharmaceuticals. Our webinars are recorded and will be made available on the EBN Health ACP Library website within a couple of weeks. This is free for all ACP members, and you can also access all the ACP Problem Solving in Oncology book series within the library. So with no further ado, I now have the pleasure to welcome and introduce our first speaker of the evening, Dr. Naureen Starling. Dr. Starling is a consultant medical oncologist at the Royal Marsden Hospital, specializing in the treatment of GI cancers, and is also reader within the Institute of Cancer Research. Dr. Starling graduated from UCL and undertook specialist training in medical oncology at the Royal Marsden. Her postgraduate degree at the ICR focused on the genomics and therapeutics of esophageal cancer. Her research interests in GI cancers are focused on earlier phase clinical trials, novel therapeutics, and the delivery of individualized medicine to patients with GI cancers. She is the principal investigator of numerous academic and industry clinical trials of novel drugs in GI cancers. She's associate director of clinical research at the Marsden and clinical lead for the Marsden's West Wing Clinical Research Centre. She serves on the UK NCRI esophagogastric and adjuvant advanced colorectal subgroups and is a member of the ESMO GI faculty and GI ASCO faculty 2022. Dr. Starling is heavily involved with training and educational roles within the NIHR training lead for the NIHR Biomedical Research Centre and is one of 4 training programme directors for the London Medical Oncology Training Programme. The title of her talk this evening is an overview of early colon cancer for medical oncologists. Dr. Starling, when you're ready, over to you. Please go ahead and share your slides.
Right, thanks for the introduction. Need to abbreviate. I'll need to abbreviate the blurb in the future. And thank you for inviting me to talk, and to the ACP Training Committee for setting up this really great lecture series and training initiative. So I'm going to talk about early stage colon cancer. I'm a medical oncologist, as Hamzeh said, and involved in clinical research. There are my disclosures. So just really to set the scene for my benefit, Jenny's benefit, could you give us an idea of have you done a lower GI oncology rotations? Number 1 currently, number 2 previously, or number 3 haven't done one yet. So if you could please vote now. Feels like we need some jazzy music down in this section. Okay, so 40% currently, 50% previously, and 10% haven't done one yet. Okay, so that's really helpful, thank you. So the outline of my talk: where were we, where are we, and where are we going? So a little bit about the history, key studies, where we are now in terms of 3 months versus 6 months of treatment, neoadjuvant approaches, current decision-making paradigms, and where we're going in the future. So ctDNA, tissue biomarkers, integration, personalization. So I think you should all know the staging. We're working to TMN 8. We don't use the Duke's classification anymore, so it's TMN. Stage 2, node negative. Stage 3, nodes involved. The T staging from the earliest tumours T1 through to the bowel, right through the bowel wall T4, and nodal status, so N1, 1 to 3, lymph nodes N2, more than 4. And increasingly, and I push our trainees on that, to define patients' tumours as high risk or low risk in each stage 2 and 3. There's a definition of high-risk stage 2. Some in the world would only use T4. In our institution, we cover all 5 of these, and I push our trainees to pull out those details from the pathology report. And increasingly and more recently, we describe stage 3 disease in terms of high risk, low risk T3N1 and high risk T4N2. And why does it make a difference? Well, it is associated with survival. In stage 2 cancers, we might expect a survival of 80 to 85% at 5 years. In stage 3, more like 70 to 75%, but actually there's detail here in terms of other risk features. And you can see that even some low risk stage 3 has a better prognosis than high risk stage 2. These are quite old now, but I thought the graph represented that well. So history, I always find history helpful and instructive and why we're going in the direction we're going, and it's good to know what happened before. So I've summarised that in 3 decades on this. So it's a busy slide, but really what I want you to take away, in the 1990s, chemo was introduced, 5FU, and that improved survival after surgery. 12 months could be reduced to 6 months of 5FU, so that was a good step forward. And there was different chemo modulation, leucovorin versus levamisole. Then in the 2000s, I was a research fellow in this period. Infusional 5FU was introduced by the French. Capecitabine could be used instead of 5FU. Doublet came into being, and that was an important step. So 5FU or K plus oxaliplatin in stage 3, and we'll come to where it fits into stage 2 or high-risk stage 2 later. And DFS became a new primary endpoint for clinical trials. That was an important step in terms of speeding the reporting of these trials. And then more recently, in this last decade, doublet chemotherapy can be reduced to 3 months for probably most patients. More discussion on that later. And where does stage 2 fit into this? Often many of these studies included stage 2, but were underpowered to show a true effect. But then Quasar came along, and we're going to look at that in a little bit more depth. Important negative studies: there is no role adjuvantly for irinotecan, bevacizumab, or cetuximab. So that really summarizes 3 decades worth of work. So coming back to stage 2, there are a couple of studies I really ask our trainees to know when they do lower GI with us, and Quasar is one of them because that provided the most definitive evidence for stage 2 disease. So over 3,000 patients, mostly stage 2 and mostly colon, a little bit mixed, but it did show a survival benefit, and that in actual terms translated to 3.6% benefit. So in 100 patients, we will cure 3.5 because of the chemotherapy. So it's rather small benefit, and it's an important part of the discussion for these patients. A couple of important things: rectum seemed to benefit as much as colon for the small rectal subcohort, and the over 70s didn't seem to derive as much benefit, which used to come in and still does come into discussion and decision making. So that's Quasar. So moving to the doublet, FOLFOX or CAPOX, but I'm going to focus on FOLFOX because Mosaic is the study we often quote in this doublet space, and this was 6 months of treatment. And this was one of the pivotal studies that introduced oxaliplatin to our treatment pathway. So the original report, 2004, 60% stage 3, 40% stage 2. There was a DFS benefit. The benefit, again, didn't seem to be so marked in the older patients, and this continues to be borne out in meta-analyses, and perhaps not as strong an effect in stage 2. With the updated 10-year survival, and this is a key figure, the survival benefit was maintained at 4.6%. So that's a figure, again, we cure 4.5 patients by the addition of oxaliplatin to 5FU. I should have said the benefit for survival for the 5FU is somewhere between 10 to 15%. Oxaliplatin adds about 4%. So again, in terms of decision making and the patient you have in front of you, this sort of stuff comes into it. And if we break that down a little bit further, low risk stage 2 didn't seem, if you look at the graph, to have as much benefit. Question really, there's a little bit more benefit, possibly a detriment in low risk, more benefit in high risk stage 2. And then if we look at stage 3, low risk, again, the benefit's rather small, but more marked in high risk patients. So again, this sort of information all feeds into individualized decision making. And why do we get so vexed about Do we, don't we, how long, and should we add oxaliplatin? Who does it benefit? Well, this drug comes with a toxicity consequence, and that is neuropathy. A number of studies now, but I've just picked out one of them that demonstrates that the neuropathy can be sensitivity to cold, discomfort, throat discomfort, muscle cramps, but also a cumulative peripheral sensory neuropathy and numbness that can be permanent. There is an effect that we see called coasting, whereby at the end of treatment, and after all treatments completed, this phenomenon might increase. And we usually quote, well, I quote, about 1 in 5 patients may still have sensory neuropathy at 3 years, and even a grade 1 or 2 effect is bothersome, and that's a quality of life impact. So that is when we were at the 6 months of treatment, we debated with the patient in front of us whether they were 80 or young, low risk or high risk, shouldn't we add in the oxaliplatin? And it was really the big driver for the next question: can we reduce doublet chemotherapy from 6 months to 3 months of treatment? And the Scott study was UK-led. It was actually international, a number of countries, a large number of UK patients, one of the largest studies conducted in this space. There are several, as I'll show you. And this was looking to demonstrate non-inferiority for 3 months versus 6 months of chemo for all patients. Most of these were stage 3. About 1 in 5 were high-risk stage 2. And it did meet the primary endpoint of demonstrating non-inferiority. And if you look at the survival curves, you can barely get a piece of paper between them. There is very little difference, a delta of 0.4%. There is some interesting detail relevant in terms of the chemotherapy used. So most of the patients had Capox, about a fifth had Folfox. And when we look at the curves, and I'll come to the forest plots, non-inferiority, the statistical premise, was demonstrated for Capox, this top graph, but not Folfox. And it was also demonstrated for low-risk stage 3 and not so much for high-risk stage 3, although the curves are pretty close together, and this delta or detriment is 1.8%. And I guess this is relevant. So for me, that is a rather small benefit for a rather large toxicity cost in terms of the neuropathy. And the overall study demonstrated non-inferiority. And that's just the forest plot again, showing that the Folfox crossed this non-inferiority bound, as did the high-risk patients. But this is a statistical construct, and I think I would always encourage you to go back and look at the curves in terms of the benefit. So what do we do when we've got, some data? Many other studies were conducting similar study, addressing the same question, 3 versus 6 months. They're shown here. The UK had the largest study. Japan also had a study which was predominantly more Capox. And they pooled these together within the IDEA pooled analysis of the IDEA global collaboration. So for the primary analysis of the first report of a 3-year DFS, not OS, DFS, early report, at a statistical level, non-inferiority was not demonstrated. Now here's 6 months and here's 3 months. And, I would argue that the curves are pretty close together. In fact, the delta for survival was only 0.9%. And remember that toxicity cost that comes with this. And so again, if we look at the forest plot, the Folfox group, there's a differential effect for chemo. So actually Capox did not cross the non-inferiority bound, Folfox did, and low risk did not cross the non-inferiority bound. So high risk did. So some took this to say, well, if I've got a low risk patient, I'm going to give them 3 months Capox or 3 months Folfox, but maybe for the high risk patients, I'll give them 6 months Folfox or 6 months Capox. Now, with the updated analysis of overall survival at 5 years, the delta overall for the whole population has diminished more to 0.4%. And if we look at the Capox group first, actually, so if for the low-risk patients and the high-risk patients, the curves are very similar. The detriment here is 1%. In fact, here it would favour 3 months of Capox rather than 6 months. So this is small, it's relevant, and some patients that I speak to will push you on this, and we'll talk about the pros and the cons. But for me and for many oncologists, this really supports 3 months of CAPOX for both low risk and high risk. For FOLFOX, you can see for the low risk, again, the curves barely separate, but they do, and there's a delta of 2.8%, still small, for the high risk patients. And so if you're using FOLFOX and you've got a high risk patient, you're probably going to need 6 months of treatment. And the benefit of the 3 months of treatment is the reduction in neurotoxicity, as shown here. Different people will have different takes, and there'll be some oncologists around the world who will always want to give high risk patients 6 months of treatment. But I think generally, and we can ask Jenny perhaps in the questions, many of us would favour 3 months of CAPOX for all, based on these curves and not just simply the statistical constructs around non-inferiority. So what about the high-risk stage 2 patients within the 4 trials? And this is a post-hoc, so take it with a pinch of salt a bit, analysis of 4 of the trials shown there. The definition, they use the definition that I would use in practice, not just T4. They had a non-inferiority bound. Non-inferiority was not met. But again, if you look at, in this post-hoc analysis, the difference for CAPOX and FOLFOX, there really is no different for CAPOX, but there may be a difference for FOLFOX. So the conclusion probably is if you're going to use a doublet for a high-risk stage 2 patient, you'd be better to use 3 months of CAPOX, because if you're going to use FOLFOX, you're probably going to have to use 6 months. That being said, if we go back to the MOSAIC study, the benefit for adding oxaliplatin in high-risk stage 2 disease is rather small. So all of these things come into play. How do you tease it all out? When you've got a patient in any of these number of categories, I think this is a really nice analysis, again, from the IDEA Collaborative, really digging down and modelling the different risk groups and what the approximate benefit of the surgery alone, the first bar, the 5FU adds, what the 5FU adds, what oxaliplatin adds, whether it's 3 months or 6 months. And I think that's pretty helpful. And I guess my take home from this is your lower risk disease, surgery is highly likely to have been curative. 5FU will add the majority of benefit if you're going to add it, and oxaliplatin relatively less, but that benefit increases with the high risk. And when, in terms of extending to 6 months, the benefit is rather small. But I do have, for instance, some patients under my care at the moment, young, got a BRAF mutant patient, where actually we have gone for 6 months of treatment because they are in this category and they are highly likely to relapse. So that's a whistle-stop tour of the adjuvant therapy. In terms of other treatment paradigms that are coming online, and I feel slightly embarrassed because Jenny is the lead for this work, and I'm depicting her work. But the Foxtrot study gives us a potential neoadjuvant paradigm. So that, and the neoadjuvant paradigm has been has traction in many disease areas, including gastric cancer, breast cancer. We're looking at it in pancreatic cancer. So the question is here, the premise is many patients don't ever get to adjuvant chemotherapy. Surgery is quite a big physiological insult. Particularly some older patients never get to adjuvant chemotherapy. So what about using a period of chemotherapy before surgery? So in Foxtrot, there was a 6-week period of doublet chemotherapy. There was a question around addition of anti-EGFR antibody, surgery, and then completion of the remaining chemotherapy that we would normally do over 6 months. Obviously, the question about 6 months versus 3 months is different. The data for that's different versus going straight to surgery and then the adjuvant chemotherapy, and for this trial, 6 months. And there was an improvement, or sorry, a reduction in recurrence-free survival for the people who had had pre and post-operative chemotherapy versus post-operative chemotherapy alone. And I think Jenny can update that now reaches statistical significance and a manuscript is under review. So the conclusion for the Foxtrot group was that neoadjuvant chemotherapy can be considered a standard option for locally advanced colon cancer. The benefit appeared to be more in left-sided primary tumour locations, T4 tumours and MMR proficient tumours. Here you can see that if the tumours were dMMR, there was really very minimal benefit. And I think that's a really important observation. And there is ongoing translational research, but watch out for the paper. And the next generation of neoadjuvant studies is depicted here. So Foxtrot 2 and 3 are soon to be launched. So Foxtrot 2 for frailer patients, so surgery versus doublet chemotherapy. For Foxtrot 3, the fitter patients, this is treatment escalation before surgery. There are cohorts that are being worked up for BRAF mutant patients, an important group, 10% of patients, and for dMMR patients, and again, in the early setting, that's about 10% of patients. So a couple of questions now. We've got a 62-year-old male patient, resected, so upfront surgery, PT4, M2B, EMVI positive, right colon, MMRP. What would you as a group advise? So no chemo, 6 months capecitabine, 6 months FOLFOX, 3 months CAPOX, or 6 months CAPOX? Right, so 46% of people would go with 6 months of FOLFOX. A third would go with 3 months of CAPOX, and a fifth would go with 6 months of CAPOX. So I think that's really interesting, really reflects some of the debates happening. So Jenny, what would your answer be to this?
I mean, as ever, it's always difficult when it's a question, not the patient sitting in front of you. I have to say, similar to you, Naureen, my main practice is to move to 3 months of CAPOX, and I think you're right. Occasionally, you get that young patient where you feel that the 6 months is definitely warranted. So I would probably still go for 3 months of CAPOX. And I think the 6 months of FOLFOX is really reserved for very specific situations. And even then, I can think of very few occasions where I've taken the oxaliplatin out to 6 months.
Yeah, so I think we're quite similar in our practice, and I think that's what I would do as well. So sometimes you use FOLFOX if there's been capecitabine intolerance or a high output stoma or something like that. But based on the data to date and the benefit versus the peripheral neuropathy, I would go with 3 months CAPOX. But you're not, all the answers. I think if you asked a whole bunch of international oncologists, you'd get variation.
I agree with that.
Okay, so the next question is, now we have a 75-year-old female who's relatively fit. She gets out and does her shopping. Resected PT3, N1, so 1 out of 3 lymph nodes, no EMVI, left-sided colon cancer. She's MMRP. What would you advise? So no chemo, 6 months capecitabine, 3 months capecitabine, 3 months CAPOX, or 3 months FOLFOX. So if you'd like to vote now. Okay, so a third would go with CAPE alone, 7% would go with 3 months of CAPE, 59 would go with 3 months CAPOX, and 3% would go with 3 months FOLFOX. Okay, that's interesting. Again, the only answer that I think here, 3 months capecitabine, I'd love that to be an option, but we haven't had the trial evidence base to reduce 6 months of CAPE to 3 months. It really applies to CAPOX. So Jenny, what would you offer this patient?
I think I would, again, the problem is 75, that covers a huge spectrum of fitness. There are very few 75-year-olds I would offer Capox to. I think that it's not very well tolerated by older patients. And I suppose you could also quote the lack of benefit with oxaliplatin, although I think that's personally a little bit questionable. So most likely I would go with 6 months of CAPE.
Okay, so I agree with what Jenny says. I put 75 in on purpose because it does, you get such variation in the 75-year-old in front of you. And for me, it would be between 6 months of CAPE. But I have used 3 months of Capox with some really fit 70-year-olds, 70-odd-year-olds. But I think the difficulty is, I think when we were in the 6 months range, of data, it was very clear from the meta-analyses the benefit for oxaliplatin in the over 70s was quite dubious. Now we're in the 3 months of Capox. We don't know quite where we are with that. So, and it's a shorter time span. But I think on the whole, it would probably be 6 months of CAPE for me, but I would consider 3 months for selected patients. And again, I think you're going to get variation in that answer. I'm glad you didn't say no chemo, because Jenny's done some work, I believe, on chemo prescribing adjuvantly for older patients in the UK, and there's quite a lot of variation and quite a lot of older patients not getting offered treatment. Is that correct, Jenny?
Yeah, a huge variation, and that will reflect different areas and socioeconomic areas of the country, but also clinician attitudes. And I think some of the idea was quite helpful in Scotland in terms of protocolizing things a bit more. But the problem with the older patients, as you know, Naureen, is that there's not a really firm evidence base for older patients. It's all subset analyses of other trials, and so that certainly doesn't help. But you know, we've done some work in our regions that between there's about 10 different hospitals to try and come up with a shared protocol for how to deal with older patients for that very reason. But we have some people, we have an oncologist in York who will see extremely well-to-do and very fit patients in their 70s, the ones you've just described, in who you would give Capox to, and that would be completely reasonable. On the other hand, you get people who may be biologically just not fit for the same treatment. So age, frailty, it's a very careful balance.
Yeah. Thanks for that. Okay, so in this last section, what I probably will skip through a few slides in the interest of time, but they'll be there for cross-reference, you know, on the for playback. So how do we prognosticate? How do you improve this individualization further? Because we've got so far, and that's great, but how can we get even further? So here we come to liquid biopsies. There's lots of things you can measure in the blood, but circulating tumor DNA, hot topic. And then what else can we do in the tissue beyond TMN? And there are a number of things that we can look at, tumor budding, cell of origin, and I'm going to cover some, but not all of these, and touch on immunoscore. So I think a few tissue markers that are important and reflected in the questions we just had. MMRD, deficient or proficient MMR status, and that is important, and we do need to check all of our colorectal cancer patients for that. So in stage 2, this was work from a while ago, including Dan Sargent's work, from pooled data from thousands and thousands of patients. And really, in stage 2, patients who are DMMR do not benefit from fluoropyrimidine. There is a fluoropyrimidine resistant. It chimes with Jenny's work as well in Foxtrot, and it's a trend we're seeing in gastric cancer as well. So in that stage 2 discussion, and again, there's a variation, and I'm not sure that I quite agree with the ESMO guidelines, but for me, for stage 2, MMR comes at the top of the decision-making tree. If they're mismatch repair deficient, when I'm not going to give them adjuvant chemotherapy. There are some who would say, oh, T4 MMRD might do, but really these are the data I use to support that decision. CDX2 expression, i.e. loss. We know from a NEJM paper that loss of that is associated with poorer prognosis and potentially lack of benefit from chemotherapy in stage 2 disease. It's very small numbers in this study, and it was never further really robustly validated, although we see CDX2 coming through as a prognostic variable in multivariable analysis and many other analyses. So we do many, I think you'll see it often on pathology reports. What about KRAS, RAS and BRAF? We know about the prognostic and therapeutic implications in advanced disease, and I think this is probably the largest series of meta-analysis looking at this based on lots of those trials I showed you, which show that BRAF mutation, whether or not you adjust for MSI, which can be a protective, good prognostic feature, is a poor prognostic feature. So going back to my young patient with the BRAF V600E mutation I talked about earlier. And more probably so for BRAF than KRAS, but similarly we did that KRAS is a poor prognostic variable. I'm not going to spend too long on this, but RNA transcriptomics is important. The CMS subtypes you will hear about. Colorectal cancer can be defined by these different CMS subclassifications, which represent different sort of molecular pathway, MSI for CMS1, canonical signaling, Wnt activation for CMS2, a metabolic pathway for CMS4, mesenchymal TGF-beta activation in CMS4. CMS4 appears in the adjuvant setting to be associated with the worst survival, and there are left and right gut associations. So far, no predictive power in this, but a lot of people have looked at how to apply this. I'm not going to go through Oncotype DX, which is another transcriptomic profile, but again, prognostic information, but hasn't really helped us in the clinic as much as, say, in breast cancer in terms of prediction or therapy guidance. Immunoscore, we probably all need to watch this space. This has been a story developing for a while, and it's looking at the immune cell infiltrate and a score that Galon has patented, so we don't know fully what's in the mixture, but immune high and immune low. And we see that Immunoscore higher scores predict for worse, sort of lower scores predict for worse outcomes. But can they be used in terms of the contribution they make to prognostication? They appears to be more than TMN. So if I'm just going to skip to this slide. So if we look at whether Immunoscore can have a predictive value, this was the IDEA 3 versus 6 month French study, and there appears to be an effect for Immunoscore high in separating out who might benefit from 3 versus 6 months of treatment in the high risk group more markedly than the low risk stage 3. So that is hypothesis generating, but really needs to be confirmed in future studies. And just to say, in the UK, we've had a great track record of leading practice changing studies, both Transcot, and now the translational studies will match that through the Transcot, lots of different translational projects, and Jenny's and colleagues' work in Foxtrot. And finally, I'm going to just summarise this in the last 5 minutes. So liquid biopsies for ctDNA for detecting tiny amounts of cancer after surgery. There are different approaches. You can sequence the tumour to track the plasma, or you can just sequence the plasma. Probably tumour-informed approaches dominate, and within the setting, Natera probably has the most studies. We know that patients who are positive for ctDNA in stage 2 and stage 3 colon cancer after surgery have a very bad prognosis. It really separates the groups. And we know that monitoring this longitudinally it gives us more robustness for the negative prognostic value. So at one time point, we still see ctDNA negative patients relapse, but if you start to do longitudinal tracking, this curve gets pulled right up. So in the future, I think it's not just going to be single time point checking, but longitudinal tracking. We also know, but this needs to be defined better with larger numbers, that ctDNA can be cleared by chemotherapy, and that might associate with cure. But again, we need this field to be curated much better. And then the plasma-only assays, one of the assays in the market at the moment is with Guardant's Reveal, and the sensitivity is increased because it has a methylation component as well as a genomic component. And it seems to be performing, but there's no head-to-head comparison, as well as tissue-based markers. So the French showed some nice data with a very simple, cheap methylation marker. This was exploratory, and patients who were ctDNA positive by their methylation marker appeared to do worse and more marked for the high-risk patients. And what we are seeing, and I'll just pull a few things out, is that the ctDNA positivity rate post-surgery is somewhere between 10% probably for stage 2 to 20% for stage 3. That we do see relapses in the ctDNA negative group if we take a single time point, but that improves with longitudinal time points. That the lead time to recurrence is probably somewhere from 3 months to 9 months with the high sensitivity assays. That most of the studies have been conducted with tumor-informed approaches, but some are with plasma approaches. And I'm just going to pick out some of the most recent data. So this with Signatera and a large US study where we're starting to get more granularity. So of the 10% who are positive with stage 2, we see more positivity in high-risk stage 2 than low-risk, and a similar pattern for high-risk versus low-risk stage 3. We mirrored that from our UK longitudinal study from the TRACK study, and I'll skip over those in the interest of time. So how may we use these for decision making? So, you know, can we pick out these patients who are already cured by surgery, right? And we are over treating them, and just treat these patients where we should offer adjuvant chemotherapy. Some of those still may relapse, but some may be cured from the studies I've shown you by adjuvant chemotherapy. So there are many studies running in stage 2 and stage 3 globally. I've summarized them on this table here, which you can always come back and reference. To pick out a few in stage 2, this is really where I see a lot of the benefit, because we overtreat a huge amount of stage 2 patients given that low benefit for adjuvant chemotherapy. And so these studies, I think, where they're looking at giving of no treatment in ctDNA negative versus treatment in ctDNA positive, and in Dynamic 2 they have a standard of care control arm similar to COBRA in the US. I think these will really be practice defining. And in stage 3, again, we overtreat a large number of stage 3 patients. Can we really pick out the ones we need to give adjuvant chemotherapy to? So mainly we're looking at de-escalation approaches, i.e. who can we remove chemotherapy? Now, if I pick out our UK TRACK study, we've got a standard of care arm for standard decision making and a ctDNA guided arm where the negative patients we will de-escalate and the ctDNA positive will continue to have the treatment. And similar studies in the US and Japan. What about the positive patients? This is an area for experimental medicine, and this is a nice US study which is looking at exactly that for the ctDNA positive patients. How about switching chemotherapy? So this is after adjuvant chemotherapy, I should say. And they're still positive, going to different chemotherapy or surveillance or targeted therapies for genotype-defined subgroups. So in conclusion, so it's a bit of a whistle-stop tour, a lot of things to cover, but you know, where were we, where are we, and where are we going? So I've shown you where we were, where we are, and I think where we're going in this next decade, to add to this diagram, is going to be far more tissue-based, blood-based, biomarker integration into trials, computation, personalization, so we can come up with much more sophisticated decision-making for our patients. And so thank you very much.
Well, thank you very much, Dr. Starling, for such an excellent talk. Yeah, I really enjoyed learning about ctDNA and how that's going to change practice in the future. Whilst we're waiting, I just had a question about in high-risk stage 3 disease and the results that you discussed about the IDEA trial. I was just wondering, do we know why there is a difference between FOLFOX and CAPOX?
It's a great question, Hamzeh. I think, you know, maybe it's to do with dose intensity. So with CAPOX, we give a far larger dose of oxaliplatin early on in the treatment course, and maybe you have to hit micrometastatic disease hard if it's there and present immediately after surgery, and maybe that 3-month window is important for doing that. I don't know, that's just speculative. I don't know if Jenny has any other views.
No, I think that's the general thinking. I don't think anyone has anything more scientific than delivery. Makes sense, though.
Thank you very much. So there's a question from Ian. Thanks for a great talk. Would you offer capecitabine capox if the patient had an ileostomy?
So I do see some oncologists really steer clear of capecitabine with ileostomies. Now it depends. Potentially, it depends on the level. Has the patient got a high output stoma? But in general, if it's low, I will, and I've got somebody on treatment at the moment, a young patient with exactly that, doing absolutely fine, and that's anecdotal. But for me, no. There may be some cases where maybe more high output stomas, history of ulcerative colitis or other inflammatory bowel disorders, where I would be more nervous about using capecitabine. And then, Jenny, what about you?
The problem with capecitabine is you can, with all the best intentions that you've done in this patient assessment, sometimes they just have very unpredictable toxicity. So we test routinely for DPYD mutations, which will identify those at extreme high risk of 5FU toxicity. But even last week, I had a man in his 50s, and he had an ileostomy, but it wasn't high output, and DPYD wild type, and I gave him capecitabine, and he was in the hospital and ended up on TPN. And had really, I think he has another variant of not managing to process 5FU properly. But of all the things as a GI oncologist, it's an absolute heart sink when somebody comes in with really bad capecitabine-induced gut toxicity. And whilst you can get it with infusional 5FU, it's certainly not as common. But like you, Naureen, for selected patients, an ileostomy always makes me stop in my tracks and really think carefully about it.
So I think that also kind of covers Chris's question. Are there any patients where you would prefer adjuvant 5FU to capecitabine?
Yeah, I think that probably covers that.
So I have the pleasure of welcoming and introducing our second speaker. Dr. Jenny Seligmann is a consultant medical oncologist and associate professor at St. James's University Hospital and the University of Leeds. In 2015, she completed her PhD on permutation of therapy in colorectal cancer. She's a principal investigator of a number of clinical trials in colorectal cancer and is a member of the UK NCRI Colorectal Cancer Research Group. This evening, she will be talking to us about the management of advanced colorectal cancer. Dr. Seligmann, when you're ready, please go ahead and share your slides.
Okay, super. Thank you for the introduction. I'm really delighted to be speaking to you all tonight. And thank you for ending your hard day of work listening to Naureen and I. Hopefully, I'll get across to you why colorectal cancer is so interesting and is such a treat to manage. It's a very much team-based sport. So as an oncologist, probably more so than in other tumour types, you're very much working alongside an MDT. The downside, as you're going to see, is that targeted treatment has not come as easy to colorectal cancers as it has for, say, melanoma and lung, which is ever-lasting frustration for all of us in the research community. So this is a huge topic to cover, and so I'm mainly going to focus on the upfront assessment of patients with metastatic colorectal cancer, firstly from a MDT standpoint, and then how I think most people, and this will be, I'll show you the ESMO guidelines, would classify patients with metastatic colorectal cancer, because the one thing that's very clear is that this is not one cancer. There's obvious subtypes, but I think within these obvious subtypes, there are further subtypes. I think one interesting thing over the next 10 years is going to be a far more personalised approach hopefully coming closer to where we are with breast cancer and lung cancer. So I'll briefly finish with on the horizon for metastatic colorectal cancer. And similar to as Naureen's done, I'm going to ask Naureen and also Chris Williams, who is about to start as a clinical trials fellow in the GI oncology unit in Leeds, and has had the pleasure of being in my clinic during his PhD. So just to have a bit of discussion around some of the facts, because there's very much variation in some aspects of practice across the world and probably across the country as well. So message number one is that initial metastatic colorectal cancer assessment starts at the MDT. And when you look at the median survival for colorectal cancer, this is huge, and probably more so than most cancers. And this is mainly owing to the fact that some disease that is metastatic is resectable, which is different from many other cancers, and that there's a prospect of long-term cure for some patients. In the middle, there are some patients who are potentially resectable, and then you have a group of patients who are unresectable. So for patients who have potentially resectable disease, what things are going through the head of the MDT? So number one, what is the site of disease? So one of the big contentious issues in colorectal cancer is the definition of oligometastatic disease. So when can you decide that a metastatic lesion is actually oligometastatic, and that by removing it or treating it, you could actually lead to long-term cure? And I'll come to that on my next slide. So, for example, you have very well documented potential resectable disease, so liver metastases, lung metastases, but more and more surgical practice is evolving. So peritoneal disease, there's two major centres in the UK, in Basingstoke and in the Christie, that deal with complex peritoneal disease, and will do cytoreductive surgery. So that's quite a different area to most people. So that's one of the first questions you ask when you're in the MDT: is this resectable? It's always very important to think of status of the primary tumour, and I'm going to emphasise that again and again and again. The role of chemotherapy with resectable disease is extremely contentious. So should you give adjuvant chemotherapy after doing a resection of metastatic disease? There's a very poor evidence base for doing that. Sometimes it's more difficult though. So if a patient hasn't had adjuvant chemotherapy, then that's more difficult. Generally, I would say if they have had adjuvant chemotherapy and they've come back with a lung met and that's been resected, I wouldn't normally treat them with further chemotherapy. Naureen, what are your thoughts on that? It's always contentious.
Chemotherapy after resection of oligometastatic disease, I agree. You know, so I mean, there was the ORTC study. So if you have upfront resectable, say liver metastatic disease, whilst the trial didn't reach statistically its primary endpoint, because there was a reasonable difference, many of us did continue with the 3 months pre, 3 months post approach. So I do that, but I guess it also depends on, in some patients where the conversion, we're not sure whether we're going to convert them to resectable. So maybe that's actually in the unresectable section. I might give all 6 months of systemic therapy up front.
Yeah, absolutely. So then that, I suppose, comes more to the potentially resectable. So then you have a group of patients who have resectable. So this is most likely, usually, when there's a higher volume of disease. Most of the time it's a question of liver disease if there's no other sites of metastatic disease. So if a patient is potentially resectable, then they would proceed to a operation with curative intent. Of course, these patients have less chance of being treated with curative intent than those with, say, oligometastatic disease, so say a lung met or 2 lung mets. And in that situation, number one at the MDT, are they a likely chemotherapy candidate? and usually you would then give them 3 to 6 months of chemotherapy, re-image, and then consider resection. Alongside that, you have to think about, well, what are you doing about the primary tumour? How is the operation going to work? Sometimes they can do just one operation, sometimes it's a 2-stage procedure, and amongst the surgeons there's always a bit of contention around, well, what comes out first, the bowel or the liver. Molecular testing, then we're going to start thinking about, well, what's their molecular profile. That will often give you an idea of their prognosis, and guide targeted treatment. But targeted treatment in the potentially resectable arena is quite contentious, particularly after the new EPOC trial in the UK showing potential disbenefit from using anti-EGFR agents. And the importance here is re-evaluation. So you do this commonly for liver disease, and almost always, if you were considering sending somebody for peritonectomy, the team would want to see the team would want them to have some chemotherapy. And in some ways that gives you an idea about their biology as well. Some patients will progress during their chemotherapy. You'd be very glad that they hadn't had an operation. Some people will have a good response. So again, it just gives you a bit more information than you had at the outset. And then there's patients with unresectable disease, and we'll speak a bit more about them in this talk. And again, many of the same considerations. One important thing is communication. So how are they getting from the MDT if they've been diagnosed with upfront unresectable disease? Who sees the patient first? How are they best informed that they have metastatic colorectal cancer? There's lots of things to bear in mind in these situations. So just briefly, definition of oligometastatic disease. So I've been writing the current ESMO guidelines, which should be out in the next couple of months. And this is something even we're struggling at that level. Chris, can you think of a couple of situations where we've had patients with oligometastatic disease and we've not really used much chemotherapy?
Yeah, I think similar to what you were just describing, where in the situation where it's metachronous and you've then had a very slowly evolving disease process, and you've managed to have a successful operation, then in someone who's previously had adjuvant chemotherapy, then further chemotherapy seems not to have such a great evidence base for it. But in the setting where someone presents with synchronous disease, then you can maybe extrapolate from the Foxtrot data and say that it might be an even stronger case for giving it these days.
Yeah, no, sure. And I think this all comes down to biology, and just to bear in mind that we're dealing with such a spectrum of tumours here. I mean, we have people who have been diagnosed, 10 years ago, and every so often has an odd bit of lung resected, or an ablation, or a sabre to a node. And so you have people presenting with, life-threatening disease at presentation. And on the other hand, on the other end of the spectrum, you've got people with very slowly progressing disease that you almost never give them chemotherapy. You're kind of giving them some targeted treatment every so often. So it just shows you the vast heterogeneity within this metastatic colorectal cancer. So number one, primary tumours are always something to think about in colon cancer, and particularly if you're on call and a patient with metastatic colorectal cancer is presenting, particularly with abdominal pain, always think about what's happening with their primary tumour. Is it been resected? Do they have a stent? Is the stent causing problems? Could the stent be perforating? Have you got tumour overgrowth on the stent? Is the tumour invading into other organs? So the primary tumours can be extremely troublesome, particularly rectal tumours. But what we do know is that there is no evidence base for resection of the asymptomatic primary tumour. So that tends not to be standard practice, but it is standard practice in most MDTs to, if you have a patient with metastatic colorectal cancer who are then coming to the oncology team for systemic treatment, you need to think about their primary tumour. So do they need to be defunctioned up front? Do they need to have a stent? Well, do you need to think about that in the future? It's always useful to have a strategy, and always useful to think in a progressing patient with metastatic colorectal cancer, what is actually going on with their primary, because it can catch you out, because it doesn't always present very typically. So you've got a patient, and this is a patient with unresectable cancer, and they're coming to you for their first patient review. So these are some of the things that would be going through my head when deciding what path they should go down. So we've already discussed about intent of treatment, and then you have the normal things that you'd be thinking about for any patients. You've got the presence of frailty, comorbidity, organ function. Organ function is important, so I'm not going to go through all the different drugs that we use and their do's and don'ts, but for example, capecitabine, you need really very decent renal function for, irinotecan and liver function. So again, you just need to be mindful of these things, and we've emphasised the point of the status of the primary tumour. We're going to come on to molecular subtypes, and then why that then puts people down completely different paths. Are they symptomatic? Are they not symptomatic? And likewise, the burden of disease. How, in inverted commas, aggressive do you need to be with your first line treatment? Primary tumour location, Naureen has touched upon. It has biological, prognostic and predictive implications. And another thing you need to think about is, have they had previous adjuvant treatment? So it's always pretty bad news if somebody is going through their adjuvant treatment and they come back with metastatic disease within a couple of months. And that would make you, that gives you again more information, and certainly you wouldn't want to be using oxaliplatin-based treatment in the first line. And most importantly, patient preference. So with most clinical situations, there will be a couple of options that you can go through. There's not a very much set first line option for all patients. There's usually a couple of options you can discuss. So these are the most updated ESMO guidelines from 2019, and you can see that the algorithm very much goes through exactly what we've just said: assessment of the clinical condition of the patients, and then think about, well, what's the goal of treatment? Is it resectable, cytoreduction, potentially resectable, and is the aim of treatment disease control? The ESMO guidelines then go into molecular subtypes, and the best molecular subtypes we have at the moment, I think we can all acknowledge are not perfect, but are based upon driver mutations or lack of driver mutations. And so I'll go through these in detail. There's a couple of things that are missing here from 2019, in particular the role of immuno-oncology in MSI high advanced colorectal cancer, and the use of targeted treatment for BRAF mutated cancers, but again, I'll come on to that. So, early response, is this important? Yes, in colorectal cancer, I think is the answer. So why is this important? Potentially conversion to resectable disease. Number two, prognosis. We know that early tumour shrinkage with first-line chemotherapy have been associated with outcomes, and that's irrespective of the treatment received. And also you've got an opportunity to get symptoms under control, and tumour shrinkage can delay the time to tumour-related symptoms recurring and improve quality of life in symptomatic patients. The other thing that's quite important is that chemotherapy in metastatic colorectal cancer is a bit of a diminished odds of return. So this is looking at the probability of receiving treatment beyond the first line. And as you can see, there's quite a drop-off. And then the probability of having clinical benefit with that treatment also reduces between treatment lines. So first line is really quite an important setting. And again, this is just showing early tumour shrinkage. So this is radiological response and showing that this is related to survival and resectability. I'll just skip through this quickly. And is resection of metastatic disease important? So this is in patients who have established metastatic disease, and I think you can see from these curves that yes, it is. And you're starting to see the differences that you're observing in the prognosis of patients with metastatic colorectal cancer, ranging from less than 2 years, with some patients out to 5 years and beyond. So resection is important. So let's move on to biology and how the patients with metastatic colorectal cancer fall into what groups. So this is a very, very simplified diagram, but I think it illustrates the point. So if you have 100 patients with metastatic colorectal cancer, approximately 50% of these will have no mutations in RAS, and 40 to 45% will be RAS and RAF wild type. And of those, a third will have left primary tumour location, and 15% will have right primary tumour location, and I'll come on to why that's important. So within the 50% RAS wild type, 5 to 10% of patients will have a BRAF mutation. And then we've got the 45 to 50% who have a RAS mutant. And then we have the really disappointingly low number of patients who are MSI high, disappointingly low because this is our target for immuno-oncology. And you can be MSI high, and most often, quite often, you'll have a mutation in RAS or BRAF as well. So that's roughly the proportion of patients that fit into each group. And this slide isn't really fit for purpose. I have to admit that I realised it was missing and grabbed it out of my last presentation, but it again illustrates a point. So what's the prognostic implication of these mutations? This is data from the Focus 1 trial, which is first-line metastatic colorectal cancer. And as you can see here, we've got the group of BRAF mutated patients and the MSI high group with the worst mutations, whereas patients who are RAS wild type do a bit better, with the RAS mutants sitting in the middle. So let's look at some scenarios. So number one, we've got a RAS wild type patient. And before I start, Naureen, is there any other way that you would classify the patients in your practice?
No, I think nail on the head. I mean, with our trainees coming through, I'm a bit of a stickler for this sort of stuff in the letters. You know, I want to know, where is the primary tumour location? What are the sites of metastases? Is it oligometastatic? Is it not? Was it synchronous, metachronous? And underneath that, we want to know the molecular profile. So RAS, RAF, MMR just rolls off the tongue, but increasingly it will be HER2 status. And as NHS England look at expanding genomic, testing, maybe NTRK fusion testing and tumour mutational burden status. Not that I've found somebody outside MSI high that is TMB high, but that kind of routine approach to these patients also then helps us decide with therapeutic decision making.
Yeah. And it really helps us give patients as much information as possible at the start. And you'd shown some data on consensus molecular subtypes, but actually we haven't found any other way of classifying the patients beyond mutation status that has really been satisfactory, mainly because what's important is having a subtype which then guides the management of the patients. So we kind of need some predictive biomarkers that then send us down the right road in terms of what path the patients should be. So at the moment, I'll describe what we have at the moment. I think, Naureen, you've mentioned one of the exciting things that are coming up in the future, HER2. Again, testing for HER2 is very patchy across the country. And I think that's really patchy because we don't have a treatment that's licensed for it at the moment. So I think many hospitals will say, well, if you're not going to use it, then we're not going to give it, which is probably not unreasonable. But again, fingers crossed, we're going to have exciting things to come, so we can we can compete with our lung cancer colleagues who have lots of exciting drugs in their armory. So number one, let's talk about RAS wild type patients. So these are usually the better prognostic group, but within the RAS wild type population, you do actually see quite a lot of difference as well. Again, all of these things are important. Intensive treatment is important in terms of, do you add an anti-EGFR to the chemotherapy if you think they may be potentially resectable? That's a very contentious topic. The thing that I'll touch on now is primary tumour location. And I'm trying to think about another cancer where the anatomy of where the tumour is influences their management. Noreen, can you think of another clinical situation? I can't.
No, I mean, biliary tract cancer, we learn is not just one thing, whether it's in the liver or outside the liver. So the location is.
Yeah, no, that's true. That's true. But I mean, this is within the guidelines. So as you can see from the guidelines, the ESMO guidelines actually goes to the point of separating out left-sided and right-sided cancers. And to be clear, there's the point of the splenic flexure is the dichotomy point, and that tends to be pretty universally agreed across the world. But it's and then you've got the you know what, we won't go into there's some debate about where the cut point should be, but it's generally agreed it should be at the point of the splenic flexure. So why is primary tumour location important? So about 30% of tumours are right-sided, 70% left. And if your embryology was excellent, better than mine was at university, you'll know that there's different embryological origins of the right and the left side of the colon. And you see lots of differences in the tumours depending upon the location. So difference is in mutation profile, in the amount of MSI high, serrated pathway signature positive, mucinous histologies, and you do, you know, female sex, younger age, maybe there may be a bit of a difference in that, whereas left-sided tumours, and that's including rectal tumours, approximately 70% more likely to be EGFR amplified and epiregulin high, which is the EGFR ligand. Also more likely to have HER2 amplification, particularly rectal cancers, and CIN. So what does that mean for treatment? So the most, what we know that right-sided tumours are associated with worse prognosis than left. But what was really interesting was the increasing story that was around primary tumour location and the efficacy of anti-EGFR agents, so cetuximab and panitumumab, which are very much the established first-line treatment alongside chemotherapy in RAS wild-type cancers. And we can be pretty convinced by that. So as you can see here, with the hazard ratio of 0.75 at the bottom, so this is across 5 clinical trials, we saw that patients with a left primary tumour did better with chemotherapy plus anti-EGFR agents. However, for patients with right tumours, who are RAS wild type, just to emphasize that point, actually we were seeing no benefit to adding anti-EGFR agents, and the most other countries that use bevacizumab would favour giving bevacizumab along with chemotherapy in the first line setting. Now, can I give you a particularly good biological explanation for that? I think primary tumour location reflects underlying biology, and it's quite a blunt tool, but it's quite a convincing blunt tool. So the nice conditions for anti-EGFR agents is that they should be given in first line in combination with chemotherapy, not limited by BRAF status, but there's many good reasons not to give anti-EGFR agents to BRAF mutant patients. You can deliver for cytoreduction. We're now allowed to give treatment breaks post first line induction, whereas we hadn't been allowed to do that previously. And we're not limited by primary tumour location, whereas in some other countries with the guidelines, you are limited. So the NCCN guidelines also say right versus left. Noreen, before I talk briefly about aerial, would you routinely give anti-EGFR agents to right PTL patients?
No, so we don't. So, you know, whilst the CDF permits it, based on these data and the meta-analyses, we don't. We equally don't have bevacizumab to give them as an alternative. So we don't give anti-EGFR to BRAF V600E mutant patients. And in fact, if you do, it makes it really challenging for them to get the EC later for their BRAF mutation.
Exactly.
So no, we don't, but there is variation. And this is why your trial is going to be so important to tease out who might benefit in the right.
Yeah, so what we've got from our previous trial that we did, Piccolo, is that we looked at a biomarker called epiregulin and amphiregulin, and actually found that indeed primary tumour location is a bit of a blunt tool, and actually you can identify some patients with the right primary tumour location who I think biologically could still benefit from anti-EGFR agents. So the aerial trial, which, and I'm going to watch my time because I know Chris is going to talk about the API scheme, is going to open in the next month, hopefully, to answer this very question. So this is randomizing people to chemotherapy plus or minus anti-EGFR if they have the high biomarker that we hypothesize will identify those that will benefit from anti-EGFR agents. So briefly, RAS mutant patients, so we can't offer them anti-EGFR agents, and these group of patients have a worse prognosis in general than RAS wild type patients, and the main decision that I make in clinic is whether to give them triplet chemotherapy or not. So this is putting some people see this as putting all your eggs in the one basket and giving people all three of our main chemotherapy agents, so oxaliplatin, irinotecan plus 5-FU, all together up front. And remember back to my slides talking about why first treatment is important. So we've got lots of data, and this has been very much championed by our Italian colleagues. So we've had TRIBE 2, and a couple of other smaller studies. And more recently, we've had a really useful meta-analysis of 5 trials, which has given us a bit extra data, because the concern is, well, what does that mean for overall survival? If you use all your agents up front, then what do you do when somebody progresses? So what they saw was that triplet chemotherapy was associated with improved overall survival compared with doublet chemotherapy, and these were all given with bevacizumab. It confirmed the PFS advantage that had been consistently shown, and resection rates as well, probably due to the increased response rate. And then what was interesting was within the meta-analysis, they had power to then look at the individual mutation groups. And the big question at the start, from TRIBE 1, it looked as though BRAF mutant patients benefited the most from triplet chemotherapy. And actually that wasn't replicated in TRIBE 2, hence the importance of a meta-analysis in a big population. And actually, out of all the mutation subgroups, actually they look like the group that don't benefit from triplet chemotherapy up front. So however, patients with RAS mutations looked as though they got really quite clear overall survival benefit from upfront triplet chemotherapy. Now, whilst all of this data is very clear, there's clearly toxicity issues. And I would say, I think it's fair to say that us in the UK give less triplet chemotherapy, certainly, than they do in Italy, where it's very much standard of care. Naureen, what are your thoughts? Do you give much?
Probably not outside the scenario of conversion therapy in oligometastatic disease. You know, and perhaps some of the younger patients in this category, but I guess where overall quality of life is the major goal, or is a major goal, you know, it can be quite hard going, this triplet. So maybe the Italians are tougher than us Brits.
Maybe the Italians are tougher. I have to say I'm giving it a bit more than I was, and I would discuss it with every RAS mutant patient, who, particularly young RAS mutant patients, I wouldn't give it beyond the induction period, so usually 12 weeks. It's quite it's quite unusual to get to 12 weeks without a dose reduction. I go hard on antiemetics, particularly for women. I think the more I'm using it, the fewer problems I'm having with it, but it's all about patient selection. But I wouldn't call this standard of care at all in the UK. I really wouldn't.
I agree with you. I think this really blew out the water. The whole BRAF mutant patients need triplet therapy, and even there, trying selecting out the patients who really in the past could benefit from it was the challenge. But that for me was what I took. The biggest take home for me was it blew the BRAF thing out of the water. That had made its way into guidelines based on very small numbers.
It really did. It really did. And I don't want to end on a sad tale here, but it was so exciting to see these sotorasib. And there was a really exciting advanced solid tumours which included colorectal cancer. And here is the data for lung cancer. And actually, when they've looked at an expansion cohort in colorectal cancer, this has been published quite recently, and it's been not quite as exciting. The other thing to bear in mind is that this is only about 3% of the metastatic colorectal cancer patient. Noreen, you were saying beforehand you have yet to find one of these patients, but we had a 9.7% objective response rate, albeit in heavily pre-treated patients. However, it was well tolerated, so whether it will be able to be developed into a combination. And there's already some scientific hypotheses as to why this didn't work so well as we saw in lung cancer. And a similar story, as I'll show in BRAF, is it appears to be escaped through the EGFR pathway. So I suspect the next thing coming our way would be a combination with cetuximab or panitumumab, which will be interesting. But as I said at the start, targeted treatment of colorectal cancer has not been straightforward. So very briefly, MSI high dMMR patients, if you remember from the graph at the start, these patients, whilst have a better prognosis in early stage, appear to do badly in stage 4. However, I think immunotherapy blows that graph out of the window completely. Unfortunately, this represents a very low proportion of the whole metastatic colorectal cancer population, approximately 5%. And actually there's an increase, this is more common in older patients as well. And I have to say that I'm not going to go into it, but there's been lots of failed attempts to give immunotherapy agents to pMMR patients, and they have been in general pretty underwhelming despite combinations with other agents, and that's very much ongoing. So let me quickly run through this. This was Keynote 177, which compared pembrolizumab to investigators' choice chemotherapy. And what we saw was a very clear benefit of progression-free survival. Couple of things to point out. Number one, you can see crossover in the curves, which is showing that some patients aren't benefiting and are progressing early, but for those that are who benefit, they not only have this statistically significant and clinically meaningful benefit, but also they've got an increase in response rate. But again, just noting this initial progression and a really decent duration of response. It's a dream to give compared with chemotherapy. Patients do generally very well, particularly on single agent. I got quite a few people in their 70s on this, and they would say they didn't know that they were having treatment. The biggest issue is usually thyroid issues. There's then combination chemotherapy, and there is a more up-to-date paper on this. Response rates higher, but I suppose the question is which are the group of patients? I mean, you're seeing the very excellent curve. Who are the patients that actually need to have the IPI added where they would have an excellent response to Nivo alone. And the other question will be, well, how can we identify these early progressors? So there's various biomarkers that are being looked at, and also in that situation, do they need a combination with chemotherapy? So those are the questions for the future. So BRAF mutated patients, again, sorry, in the interest of time, I'll skip through. We were all wanting to give them triplet chemotherapy. This data blew it out the window, so we give doublet chemotherapy, and generally that's with oxaliplatin. Targeting BRAF has also been a journey. You'll be aware of the excellent BRAF inhibition story in melanoma, which they did then add a MEK inhibitor, but with colorectal cancer, there was the original paper, which again showed very conservative response rates. And then there was a very beautiful paper. I thought this is just one of my favorite papers, which looked at cell line studies and actually found that the unresponsiveness to BRAF inhibition was through feedback activation of EGFR, which then led to the clinical testing and has now led to standard of care, which is, this is the Beacon trial, and to cut a very long story short, we give the BRAF inhibitor along with the anti-EGFR agent, so cetuximab, and that's a very clear difference and clinically meaningful difference, and that is given in the second line, but we will be awaiting data in combination with chemotherapy, and also the final results of the first line cetuximab. So other considerations in the pathway, we could talk all day about maintenance treatments. In fact, I did talk for 20 minutes about it last week. That's a whole separate can of worms. So can you give people treatment holidays, or do you need to continue maintenance chemotherapy? Second line options, usually with the chemotherapy combination you haven't used in the first line. VEGF, so bevacizumab, isn't reimbursed in the UK, so therefore we tend not to use it out with private practice, which is quite an outlier compared to our European and American colleagues. And Lonsurf TAS-102 is licensed in the third line. One thing to say, clinical situations may change, so you may have somebody who you think was initially unresectable, and you may want to go back and look at that decision again. If you have oligoprogression, in other words, you need to have your friends on the MDT in hotline, and you need to continually question your approach and think, well, can I give a targeted approach? Can I do this differently? And I think that's one of the things that I enjoy the most about treating colorectal cancer. And please remember primary tumour status when you see one of these patients. Future directions, EGFR re-challenge is a huge topic of interest, using ctDNA to identify patients who have acquired, or more importantly, lack of acquired mutations. So this is another really lovely trial, Kronos, which looked at giving re-challenge EGFR to patients who remained RAS wild type. So when they progress on anti-EGFR agents, most patients get RAS ectodomain mutations, but if they tend to reduce over time, which then gives you a window to retreat. HER2 is the other thing that's exciting, and I think we need better guidelines for frail and older patients. So I'll finish there. Thank you very much for your attention, and Chris, I hope we've got enough time to get your API talking.
I had a question briefly just about what you mentioned about triplet therapy in selected patients with RAS mutated tumours. I just wondered, so once those patients then progress, would they be candidates for re-challenge, and how would you decide that?
So I would usually give induction chemotherapy, usually with maintenance, quite often with maintenance capecitabine, and then I have usually retreated with either irinotecan or oxaliplatin. So I haven't gone back in with a triplet because I just think that's too much. That's probably not an evidence-based approach, but I think it's just very clear that this initial, it's coming clearer to me the more I look at it, that this very early period is really important. So I would treat intensively then, and then back off, and then go back in with normal doublet chemotherapy after that.
Great, thank you. So we have a question from Aman Singh, which is, would you treat a patient with synchronous solitary liver met who is otherwise T3N0 and has no other high-risk features as high risk, and offer them chemotherapy in the adjuvant setting if they had upfront surgery of primary plus MET and have not had any neoadjuvant chemotherapy?
Usually, yeah. I mean, you know, they've got metastatic disease, so therefore they have the highest risk because they have established metastatic disease. So yes, I mean, with all of these guidelines, there are some grey areas, and I would usually offer that patient chemotherapy.
Yeah, I'd agree with that.
So Dr. Chris Williams will now provide some information on the NIHR Associate PI Scheme, which may be of interest to many of our trainees. Dr. Williams is a clinical research fellow at the University of Leeds and is currently working on the Foxtrot trial. So Dr. Williams, when you're ready, please go ahead and share your slides.
Thank you very much, Hamzeh. So yeah, it's just, we've been hearing a lot tonight about some very exciting progress in colorectal cancer research. And you've also heard a lot about how much of that research has come from the UK. And so I'm just going to talk briefly tonight about a way in which you can become involved in that research in your local area. So this is to do with the Associate PI Scheme, which has been designed and established by the NIHR. And there are lots of different trials through which you can join this scheme. And my disclosures is that I'm working on the Foxtrot and aerial trials at the moment, and so I'll talk about it in that context. And what it gives you the opportunity for is to work alongside the principal investigator at your local recruiting site for an open and recruiting trial. And it gives you the opportunity to learn about the tasks that the PI performs, and also to be mentored by a clinician who's actively involved in research. Any health professional can take part. It doesn't have to be a oncology trainee. It can be nurses and allied health professionals as well can get involved. But crucially, it has to be someone who's going to gain something from the course. So it's not usually beneficial for people who have already got a funded research position. But there may be some exceptions to that, and you can look into the scheme and see what you might be able to gain from it. The commitment that's involved is a 6-month period where you work alongside the PI contributing to the trial. You gain experience in what's involved in performing a trial at a recruiting centre, and you complete a set of activities in an online checklist. And in return, you get recognition from the NIHR as an associate PI. And in the Foxtrot and aerial studies, you would, and this is dependent on the study you're involved in, then you get acknowledgement in publications, which is PubMed citable. The core activities that everyone has to perform, and there's other activities that you can perform additionally as optional ones, but the core ones are really just being a member of the team on the ground in the site, getting involved in everything to do with the delivery of the trial. So it's in getting everyone on board at the local site, disseminating news about the study and who are going to be the potential recruits to all the different teams in the hospital, attending the study delivery meetings, and being personally involved in recruitment and consenting. And you contribute to the PI tasks as well, training the site staff in what's required of the protocol, and doing things like reviewing screening logs and toxicities. And a lot of this maps to the physician academic checklist, which all trainees in registrar posts have to complete and demonstrate competency in before CCT. So there's sort of a double win for people here as well. And in terms of the benefits to the PI on the site, this involves obviously a bit of effort from the PI in bringing you along with them, but the benefit to them is insistence in delivery of the trial and insistence in disseminating it across the department. And for the trial as well, then we know from the pilot studies of this scheme that this has been really effective at improving awareness of trials at sites and improving patient flow and recruitment to the trial. So it's benefits for everyone, really. So for our trials that are opening this year, so we have 3 trials opening this year, Foxtrot 2 and 3. We've heard about Foxtrot 1, and indeed Naureen did mention these 2 studies as well. This is about tailoring neoadjuvant chemotherapy to individual patients in colon cancer. And the aerial trial that Jenny mentioned in the advanced setting, where we're looking at are there any right-sided patients who we can tease out who might actually stand to benefit from anti-EGFR therapy. And we're opening this month in Birmingham, Edinburgh, Fife, Huddersfield, Leeds and Leicester. And then in the first half of 2022, then we're opening at a number of other sites around the country. So there should be a chance for lots of people to get involved. So I just wanted to leave this QR code, which will take you through to the NIHR API Scheme website, where you can read a bit more about it and see the other studies that you can also be involved in through the scheme. And there's my contact details as well, if anyone wants to get in touch about these studies specifically, and I'll be very glad to talk to you about them. So thanks very much for your time this evening.